Hello, Assalamu alaikum. How are you guys? Today, I'm going to talk about neonatal upper airway obstruction. My name is Dr. Banayat. If you like this presentation, please share and subscribe me, okay? I have no financial disclosure. This is a presentation for educational purposes. The learning object of this presentation to understand the anatomy of the airway. It's very important to understand the anatomy of the airway, to understand the difference between infant versus adult airway. And then we're gonna talk about neonatal stridor. What's the difference between stridor and the wheeze? And then the differential diagnosis of the neonatal stridor, whether inspiratory, expiratory stridor, bivasic stridors. And then we're gonna talk about the different causes of the neonatal stridor, including choanal atresia, laryngomalacia, focal cord paralysis, subglottic stenosis, and vascular ring. So we will start with the airway anatomy. Airway anatomy is very, very important to understand the airway anatomy, because without it, it's very hard to understand the cause of the airway obstruction. So airway obstruction, we can divide it into upper and lower airway obstruction. So we divide it to the upper and lower airway obstruction. When we said upper airway obstruction, we are talking about stridor. When we talk about lower airway obstruction, we are talking about wheeze. So any obstruction in the lower airway, we called wheeze. The sound that made is called wheeze. The obstruction in the upper airway, the sound they made called stridor. Okay? What does it mean upper airway? Any obstruction start from nose all the way down to the right and left main bronchus. That's when we call upper airway obstruction. Anything below that usually are lower or lower airway obstruction, okay? So anything from the nose, obstruction in the nose, all the way down to the right and left main bronchus, we call upper airway obstruction, stridor. The sounds that they make, stridor. Any obstruction in the lower or beyond that point usually cause wheeze, okay? So that's the first concept. We need to understand it very well. The second concept, I would like to make sure you guys understand it. The upper airway, we classify the obstruction into extrathoracic and intrathoracic. Anything inside the thoracic cavity, that's called intrathoracic. Anything above the thoracic cavity, we call extrathoracic. Why it's important? Because obstruction intrathoracic usually cause expiratory stridor. So obstruction here, and we will mention what this means, usually expiratory stridor. Okay. So obstruction in upper airway, obstruction in upper airway, I'm talking about upper airway. Intrathoracic, we call it, usually it make expiratory stridor. What does mean intrathoracic? Means trach, bifurcation, or sorry, carina, and then right and left main bronchus. So any obstruction intrathoracic in the trachea, intrathoracic trachea, or part of the trachea, intrathoracic part, carina, right and left main bronchus, usually cause expiratory stridor, and we will discuss later on why. Any obstruction at the extrathoracic, it can give you, usually it give you inspiratory stridor, but can give you also bivasic stridor if condition obstruction below at the level of the focal cord or below. So obstruction at the level of the focal cord or below, usually inspiratory, but can be bivasic. Any obstruction above the focal cord, usually inspiratory stridor, or usually give you inspiratory stridor. So let's divide it, the extrathoracic. So extrathoracic classified to supraglottic supraglottic or glottis, and subglottic. The supraglottic, it could be oropharynx, nasopharynx, oropharynx, laryngopharynx. That's the supraglottic area. So supraglottic to the nasal, oropharynx, and larynx or laryngopharynx. Glottic, which is at the level of the vocal cord, subglottic area, and then the last part is the trach that located at the extratracheal trach. That located in the extrathoracic area. Again, so at least to memorize, we have extrathoracic, we have intrathoracic. When we said intrathoracic upper, I'm talking about stridor, upper airway obstruction, we mean, what does mean? The obstruction at the level of the trachea, intrathoracic, carina, right and left main bronchus. When we said the obstruction at the extrathoracic, it could be anywhere, supraglottic, glottic at the vocal cord, or subglottic, or the trachea, extrathoracic tracheal part. Is that clear? Okay, very good. That's summary what we discussed. So you can guys pause and read it because that's what we mentioned. Okay, so then there is another terminology called larynx. What does mean larynx? Larynx, if you see this portion, the yellow part, that's what we call larynx. It's made from epiglots, which is part of the supraglottic, vocal cord, which is glottis, and then subglottis. So that's piece of the cartilage, the yellow piece, epiglots, which is supraglottic, glots, subglots, that's called larynx. So when you intubate the baby, you will see this one, correct? So when you intubate the baby, that's epiglots. The shape is different from the newborn, infant, or pediatric to the adult. In the newborn, usually it's more U-shape or omega shape, versus in adult, usually flat. And in pediatric, a little bit in between. That's the true focal cord. And then there is fold here called vestibular fold, or the false focal cord. Inside you have the clots, that's at this level is called, inside it subglottic and the trach ring or the trachea. Okay, very good. So now the true differences between adult, what difference? Why in the infant or the neonates, the intubation is more difficult than adult age group? Why? Because the airway itself is different from pediatric or neonates to the or infant to the adult. We will start with the tongue. The tongue in the infant or pediatric age group, adult age group. Number one, the tongue is larger in proportion compared with the, or larger in proportion to the mouth. The second, the pharynx is the smaller in pediatric age group than larger in the adult. The third part is the epiglots part. It's more floppy. Okay, as I said, the shape, it's the different U shape in infant or the neonates, and then more slightly flatter, and then flat in the adult. In the adult, the epiglottis is more shorter and flat. Okay, when we discuss about the larynx, and now we know what does mean larynx, it's more funnel shape in the pediatric age group, shorter and funnel shape. And the narrowest part, and that's the board question, the narrowest part in the larynx or in the airway were located at the subglottic, and that's why subglottic stenosis is very common. That's why subglottic stenosis or stenosis occur at the subglottic area, because this is the narrowest part of the body, okay, of the airway. Where exactly? At the cricoid ring. This is the narrowest part. Compared with the adult, is more cylindrical shape, longer tube, The focal cord is the narrowest part in the adult. Okay, so the tongue is larger, epiglottis is more floppy, U-shape. The pharynx is smaller, and then the whole larynx is funnel, short. The larynx located in the neonate at the level of the C2, C3, versus in adult located at the level of the C4, C5, and some reference C4, C6. Okay, very good. So let's see the beautiful images here. So you can see in newborn, it's more omega or U-shape, a little bit difference in pediatric age group, and then more flat in adult age group. And here is the summary. You can guys read it. We already covered most of these, okay? When another important, we need to discover the differences in pediatric and adult airway, the angle between the tongue and the glottis opening. If you make a line or plane line between the tongue and glottis opening, you will see it's almost acute angle than in the adult. So you can see that's the tracheal axis and that's oral axis. Oral axis, when you look, you cannot see the airway. That's the airway down. So that's why we usually use the straight laryngoscope blade to push the tongue down so you can visualize the airway. Okay. Also, we already mentioned the larynx located in infant at this level of the C2, C3 versus later on C4, C5, or C4, C6 in the adult age group. Okay, so now we discussed already about the anatomy, airway anatomy. We discussed the difference between the adult and pediatric airway. We already mentioned anytime you hear stridor, you indicate upper airway obstruction. Let's see how the sounds looks like, or how the, if you listen to this sound, you will hear it's more, it's inspiratory stridor. Let's hear. He's crying. Cry. Okay, so his baby already inspiratory stridor. Okay, that's back. Okay, so we discussed that any obstruction intrathoracic will cause, when we said intrathoracic, let's revise what we understand. Intrathoracic means at the trach, the intrathoracic trach, the carina, and then the right and left main bronchus, correct? That's usually cause expiratory stridor. It's less common, but usually it's more serious. Correct? Correct. Also, we said anything above we called extrathoracic. We divided to the supraglottic, glottic, infraglottic, correct? We said any obstruction above the focal cord usually or give you inspiratory stridor. So inspiratory stridor, usually supraglottic obstruction. We are talking about either nasopharynx, oropharynx, or nose, nasopharynx, oropharynx, and the hypopharynx. The characteristic of the inspiratory stridor usually worse, especially when we talk about laryngomalacia, it's worse with the position, supine position. When the baby lay back, it's getting worse, the stridor, versus baby on the prone position. If the level at the focal cord or mainly subglottic Then usually bivasic, you hear both inspiratory, expiratory. Okay, we will explain why. So the question is why in the stridor extrathoracic we hear mainly inspiratory, intrathoracic we hear expiratory. The same for the wheeze, we hear mainly expiratory unless a severe obstruction. Then you hear bivasic in both. To know the answer, we need to go a little bit difference in the pressure between atmosphere pressure and the tracheal pressure at the level of the extrathoracic. Let's go to the intrathoracic and then we'll come back to the extrathoracic. At intrathoracic, there is very, very important pressure that we need to understand, which is the pleural pressure, usually negative. What happens during inspiration? The negative pressure become less. So pleural pressure become less. When you have less pleural pressure, the tracheal pressure become stronger than the pleural pressure. At the time, what happened when you have inspiration, the negative pressure, the airway, what happened during inspiration? It's open because of the decreased pressure in the pleural. So the tracheal pressure become stronger than the pleural pressure. And that's why it's bronchodilator during inspiration. In expiration, when you exhale, it become more negative pressure in intrapleural than the intrathoracic or than the pressure in the trachea. And that's when we cause bronchoconstriction, vasoconstriction, or bronchoconstriction. And that's why we are talking about intrathoracic you hear inspiratory stridor, sorry, expiratory stridor, not inspiratory. We said because during inspiration, it's the bronchodilation versus in expiratory is bronchoconstriction. And that's why the stridor here during expiratory phase. Let's go. Now, extrathoracic. In extrathoracic, the difference between, there's no pleural pressure effect here in the pleural. There's only two pressure, it's atmosphere versus tracheal pressure. So during inspiration, the tracheal pressure, it's lower than the atmospheric pressure. When the tracheal pressure is lower than atmospheric pressure, then it's gonna cause constriction. Versus during expiration, it's go opposite. The tracheal pressure become higher than the atmospheric pressure. And that's why you have the dilatation. So that's why during outside, it's during inspiration, what happened? Constriction. Versus dilatation during the expiration. So that's why extrathoracic we have inspiratory. The reason why, because the tracheal pressure lower than the atmospheric pressure. In fact, or an opposite, in the intrathoracic, because of the during inspiration, you drop your, during inspiration, what happens? You drop your pleural pressure, so tracheal pressure become more than the pleural pressure, and then you cause the bronchodilation, okay? Hopefully it's clear. Now, what's the cause of the inspiratory corridor? Now, think any cause. And here, I need you guys to focus. I'm talking about all inspiratory, but today we are focused, since I'm mainly neonatologist, I'm focused in the neonatal stridor. Neonatal stridor. Nobody asked me why you said the most common cause of the neonatal stridor, why most common cause of the stridor is laryngomalacia. I'm talking about neonatal stridor. I did not talk about at the pediatric age group. It's clear? Okay. So the most common cause of the inspiratory stridor, mainly congenital in the neonatal stridor. You have the laryngomalacia, you have the focal shows. Just think about it, inspiratory. So that means extrathoracic. You have the larynx, laryngomalacia, you have the focal cord paralysis, you have the tongue, which is Berber syndrome or sequence, the tongue backward and obstruct the airway. You have the larynx, laryngohemangioma, laryngeal web or cyst. You have the focal cord paralysis or focal cord edema, that's secondary to the intubation or the prolonged intubation or traumatize or manipulate the airway. You have the congenital extrathoracic, we are talking about extrathoracic tracheal stenosis or tracheomalacia at the extrathoracic lesion. Okay, very good. And later on in the pediatric age group, you have the tonsillar hypertrophy, foreign body aspiration, retropharyngeal abscess, and epiglottitis. The bivesic stridor we are talking about at the level of the mainly focal cord or the subglottic. Because of the subglottic is the most common area narrowing, we have the subglottic stenosis or hemangioma. Versus in the acquired later on, also it might be stenosis, papilloma, or foreign body aspiration. The cause of the expiratory stridor, we said mainly, when we said expiratory, we are talking about intrathoracic. So any obstruction, any lesion structures that located around that area, it can cause stridor, correct? We are talking about vascular ring. We will talk about later on. Any aorta arch anomalies, tracheomalacia at the intrathoracic lesion, tracheal stenosis intrathoracic also if there is lymph node enlargement or left atrial enlargement or pressure. Then, okay, you have a baby who presented with a stridor. Then the question is, what's the diagnostic approach? How to evaluate baby with stridor? Usually, when you have a baby with stridor and you involve the ENT, the number one, what they're gonna do, they're gonna do the direct laryngoscope. They're gonna use mainly, so direct laryngoscope could be flex, it could be rigid. Most of them, they use flex fibro-optic direct laryngoscope or nasolaryngoscope, which is scope the go either to look at the larynx all the way down or through the oral all the way down, okay? It's used mainly to assess the degree of the laryngeal collapse, and they look at, because of the flex, they look at the focal cord dynamic motility. So when you hear flex, we are talking about dynamic motility, okay? Then, because some cases, if the physician concerned that it might be secondary, another lesion associated with this obstruction, then he might request, especially in severe cases, he might request, or baby looks syndromic, he might request to do more advanced, which is called flex bronchoscopy. Or in case the lesion it's above, or sorry, below the focal cord, because with the laryngoscope, you will gonna visualize just at the level of the focal cord, anything above the focal cord level. If you think that there is something below the focal cord, then you need to request either flex bronchoscopy or rigid bronchoscopy. Rigid bronchoscopy mainly done by the ENT versus the pulmonologist. Usually they use flex bronchoscopy. Flex bronchoscopy usually used for mainly to evaluate dynamic of subglottic airway and lower tracheobronchial tree in the lower airways. And that's why used mainly by the pulmonologist. Versus rigid bronchoscopy, which is usually indicate in critical ill infant, especially if the foreign body, to remove foreign body. And also, if you want to visualize below the focal cord, but this technique need complete sedation. So you have to take the baby to the OR. Okay. We discussed about the anatomy of the airway, the difference between the pediatric and adult airway, and we discussed about the cause of the stridor, what the mean stridor, upper airway, inspiratory, expiratory, bivesic stridor. Now we're gonna talk about the cause of the inspiratory stridor. The first, we're gonna talk about choanal atresia. Choanal atresia is obstruction in the nose, correct? At the posterior nasal apparatus. It's secondary to the incomplete rupture of the buccopharyngeal membrane or abnormal dense cartilage occlusion. The most important, it can be bone or bony in 30%, or mix, bony membranous, which is the most common. 2/3 of the cases usually unilateral, but it can be bilateral, which is more severe. Right more than left, girls more than boys. Okay. How usually they presenting? It depends, correct? If the baby presented or baby has bilateral choanal number one, the learning, baby's obligatory nasal breathing, correct? So that means baby, they cannot breathe through the mouth unless they start crying. So if the baby has, it's a breathe only through the nose, and then you obstruct the both nose, what's gonna happen? Baby's completely cyanotic. And when he cry, and that's the true emergency, immediately at the delivery room, baby is completely cyanotic, but when the baby starts crying, the cyanosis get less because start air coming from the mouth when he crying, and the cyanosis get less. So that's the complete airway obstruction, and that the choanal you can see is complete obstruction. And that's the true emergency. Versus if you have baby with unilateral choanal usually it's mild, can be present with the DSAT, just DSATs, intermittent DSATs, or it can be discovered later on with the nasal discharge and obstruction. And you can see it is open, and this one it's blocked, and this one is open. Okay. How can I diagnose it? If I have highly suspicious of choanal then I have to ask the feeding tube and try to pass the catheter through the both nostrils. If I'm unable to pass the catheter, that's enough to diagnose. You also can request the ENT to come, especially if you are not doubt, especially in the unilateral condition where you are not 100% sure whether obstructions, stenosis, then the ENT, he will come and then he can do the direct fibro-optic or flex fibro-optic nasopharyngoscope, and he can look at the nasal airway, and he will say, okay, I didn't see anything. It looks like complete obstruction, or it looks like stenosis. The definitive diagnosis, and usually if need surgery by doing CT scan or MRI, especially to differentiate between, it's important to differentiate between bony versus membranous or bony membranous, stenosis versus atresia. Okay, so you can see here is the axial view of bilateral choanal atresia. You can see it's bone, complete obstruction. Versus in this side is still open here, and you can see here it's the bone and then membranous. Okay, so you can see it. Okay, 50% of cases of choanal atresia is associated with or part of the syndrome, like tracheal colon syndrome, Charge syndrome, which is stand for coloboma of iris, heart defect, atresia or choanal atresia, retardation, growth retardation, genitourinary abnormality, and ear abnormality. Deafness. Kalman syndrome, vectoral or VETR. Vectoral stand for vertebral anomaly, anal atresia, cardiac defect, tracheoesophageal fistula, renal, and then limb anomalies or limb defect. This is a picture of the Fiver syndrome. Also can be associated with, can be presented with choanal atresia. How treat choanal atresia? If the baby has bilateral choanal atresia, then it's a true emergency. You need to place the oral airway and then prepare for the surgery. The surgery usually either intra or transnasal puncture and stent, or is it definitive surgery or endoscopic resection of the posterior nasal septum. And that's, you can see the stent. If baby presented with unilateral nasal or choanal atresia, as I said, usually intermittent, otherwise baby looks fine, then you can wait, just management supportive only, and usually the surgery is around 4 to 5 years of age. Okay, For resident and medical students, choanalgesia, the one clue you need to differentiate when you read it is baby cyanotic at birth. When baby cry, the cyanotic it become less. That's the clue. Okay. The next step, place the NG to see if you are able to pass the NG in both nostrils. That's what you guys need to know. Okay, very good. Laryngomalacia. Laryngomalacia, it's the most common cause of the neonatal stridor. I'm talking about neonatal. Okay. Sorry. It happens during inspiration. Let's see. You can see here, open, inspiration, expiration, inspiration. You see how omega shape, how severe type, and how completely can be completely obstruction. You can see there is no way for airway during inspiration. That's the very, very good. That's the laryngomalacia. Okay, very good. What's the cause? Nobody knows, but there is proposed mechanism that can be indicate or can be delay maturation or hypotonia of the cartilage. It can be redundant of the soft tissue. It can be underlying neuromuscular disorder, or there suggests some inflammation and edema of the subglottic area. How usually baby presented with laryngomalacia? What you need to know for the laryngomalacia? It's very, very important to know that the baby positioning stridor. What does it mean? When the baby is on the back, the stridor is getting worse. When you put the baby on the moment you take the baby and put it on the belly or the prone position, the stridor decrease or stridor disappear. So that's the clue in the diagnosis of the laryngomalacia. The presentation, it can be mild, just mild stridor. It can be severe, depending on the degree of the laryngomalacia. In severe cases, they can present with respiratory distress, some retractions, poor feeding, stirred disorder breathing, and failure to thrive. Up to 20% of cases, it might be part of the syndrome, like Digeorge Down syndrome, okay? How to diagnose? History, history, history. And then if you are doubt about diagnosis, then you can confirm it by the direct laryngoscope. We call it, or they use fiber optic, flex fiber optic laryngoscope. You can see how during expiration, because it's open airway, you can see omega shaped, completely obstructed. And there's various degree of the laryngomalacia. The management. The management of the laryngomalacia, if there is mild, maybe stable, just mild stridor, then conservative. Usually resolved by 12 to 18 months. In moderate to severe symptoms, especially if usually what we do, usually we give time, reassure the parents that take time, is going to go away. But if the feeding get affected, baby still has required respiratory support, despite that you give him time, you give him time, then unfortunately, in some cases, you need to do surgery by taking out the extra tissue. That's called supraglottoplasty, which is remove of the redundant supraglottic tissue. The issue with this procedure, there is risk of the recurrent chronic aspiration or dysphonia. If this one doesn't work, unfortunately, it's very, very rare, they require tracheostomy. But majority of the laryngomalacia, usually conservative treatment. Okay. Now, we're going to cover the focal cord paralysis. It's considered second most common of the inspiratory stridor. What I need you guys to know in the focal cord What's the function of the focal cord? Is the two: airway, adduction, abduction, and phonetic sounds, correct? Or protect airway and sounds. So the focal cord supplied by vagus nerve. The second most important I need you guys to know is that left recurrent laryngeal nerve is the most or left recurrent laryngeal nerve. This nerve is most likely get injured than the right recurrent laryngeal nerve. The third most important, I need you guys to know that if the baby has focal cord usually present with stridor and voice involved, so it's going to be hoarseness of voice or soft voice. That's the clue for the board, okay? So let's go overview very quick. It's inspiratory stridor. Second most common, either unilateral or bilateral. It could be complete or partial. It could be congenital or acquired. How you gonna remember left recurrent laryngeal nerve from the right recurrent, which one? Just remember, left has a long course, so more likely to get injured. Versus right, recurrent laryngeal nerve is go right away, so it doesn't short right away. But left, it's come from the vagus nerve. You can see around the ductus arteriosus and then aortic arch and then all the way back and supply the focal cord. Okay. The cause of the focal cord paralysis mainly acquired. Mainly what? Mainly acquired, yes. It happens iatrogenic, secondary to the PDA ligation or any cervical surgery, secondary to traumatized delivery, direct trauma to the focal cord from the recurrent suction, from the repeated intubation and unsuccessful, or from the prolonged place baby on mechanical ventilation. In congenital focal cord paralysis, so now we discuss about acquired. Congenital focal cord paralysis, we are talking about Chiari malformation. We are talking about hypoxic ischemic encephalopathy. We are talking about any CNS cause. We are talking about that might interfere with the vagus nerve. It causes about myasthenia graves or graves, infection, familial inherited. Okay, but just remember it's mainly acquired. So this may be a picture of the unilateral focal cord paralysis. You can see this there during the airway open. So you can see this one, it's already paralyzed. This one is already abduct. So that's indicated left focal cord paralysis. And that's through the fibro-optic laryngoscope because we know that is not just looking from outside. During adduction or during the close of the airway, you can see this one is moved toward the adduction and the left side still paralyzed. So this one unilateral focal cord paralysis versus bilateral focal paralysis, both of them, they are not moving. Okay. How baby presented? We said correct, usually inspiratory, but can be bivisic. The most clue is the hoarse voice or weak crying. In the unilateral, usually the presentation is mild. In bilateral, usually presentation is severe. And in the picture is the same as any cause of the inspiratory stridor. Very, very few differences. This baby also at risk of the aspiration of the oral feed, recurrent cough, which is secondary to maybe micro aspiration, dyspnea, or short of breath. Another clue, inability to wean from the mechanical ventilation. How to diagnose focal cord paralysis? By the fibro-optic laryngoscope, direct laryngoscope. But also you need to make sure that you rule out other causes. You look for the other causes. You need to do the chest X-ray. Make sure that, especially if baby has a recurrent aspiration, you need to do a rarely required barium swallow, a chest X-ray. Also, you need to do some cases you need to do head scan and neck to rule out other causes. Sorry. Management, number one, and for any airway obstruction, focus on the airway. 50% of the bilateral required tracheostomy. For those unilateral and or mild symptoms, a baby presented with mild symptoms, always observe, because resolution around 2 to 9 months of age, and any intervention, it's very important to keep it at least 1 year of age. And the prognosis is good if second to the unilateral and second to the stretching in the nerve. In some cases, that doesn't work, then you need to do the arytenoidectomy or focal cord lateralization, which is done around 9 to 12 months of age. What does it mean? That's the cartilage, the arytenoid cartilage, either partial or bilateral removal, and you can see it to open the airway, or lateralization and sutured. The prognosis depends on the etiology. It's good and full recovery. It's second to the stretch or partial injury, the focal cord. So if idiopathic, around, and that's different from what literature from others. So 64% if idiopathic, post-op around 46%, 35% resolution or recovery after surgery in those microbremia, especially post-PDA. Okay. Next topic, it's subglottic stenosis. Subglottic stenosis, when you have a narrow less than of subglottic lumen less than 3.5 millimeter, we call in the newborn, we call subglottic stenosis. Also, it can be congenital or it can be acquired. The congenital part usually is shared with other anomalies. The acquired is more common and more severe type. And usually secondary to, because of the narrowest part, intubation. And that's why when you have baby who's getting a leak, think twice before you decided to place a bigger tube. Okay? Because always you're going to carry risk of the subglottic stenosis. The cofactors for development of acquired, including reflux, esophageal esophagitis or eosinophilic esophagitis. The presentation is the same, either mild, varies from mild to severe airway obstruction. Maybe recurrent respiratory infection or recurrent croup. Especially in the first year of life, you consider and you should evaluate for the subglottic stenosis, congenital type subglottic stenosis. So when you have a child who's a recurrent croup, one of the consideration you should evaluate for subglottic stenosis, congenital type. Okay. What's the staging for the subglottic stenosis? So the subglottic stenosis is divided by the grades from grade 1 to grade 4. Grade 1 from no obstruction to the 50%. From 51% to the 70%, that's grade 2 of the obstruction. You can see the lumen. Around 71% to the 99% of obstruction, that's grade 3. It's completely, you cannot see the lumen. That's you are grade 4 was a true emergency. Okay. The management close to be the similar for the others. If mild, always if mild, especially grade 1 or grade 2 or asymptomatic, then observe, mainly respiratory, supportive therapy. For those grade 3 to 4, usually required tracheostomy. And then for the long run, when you recannulate them, in order to achieve recannulation, you need to do either the laryngotracheal reconstruction resection or partial cricothyroid resection. Please, there is 2 YouTube, you can watch them in order to differentiate the difference between 2 procedures. It's very nice videos. It's highly recommended to watch them. Okay, let's talk about the last topic is the vascular ring. Okay, before we discuss about the vascular ring, it's very important to understand the embryology of the heart. As we know, the heart begins early from the mesoderm structures within the triluminar embryonic sac from the area called cardiogenic area here. The heart begins by formation of the 2 tubal structures. This one, 2 tubal structure, around 20 days of life. This later on, those tubes is merged together and fused, and that's formation of the heart tube, 1 tube, okay? After that, certain changes happen in that tube, dilatation, and form 4 parts. The trunk arteriosus, and the way you think about it, you flip it. So trunk arteriosus, bulbus cordis, ventricle, and then the primitive atrium. If you think the heart usually start with atrium and then ventricle and then trunk arteriosus, which is then it give you a rise of the aorta and pulmonary. But here, before that, it was opposite. So trunk arteriosus, bulbus cordis, and then ventricle, primitive, and primitive atrium, and then start changing. So start this part is go down and this part go up, and you can see the shape of the heart formation. So why you have to bring all these now? To discuss about this piece. Above the trunk arteriosus, where's the aortic arch? So the aortic arch, you can see here trunk arteriosus, and then the aortic arch start formation or form the several segments or several pairs of the arches, aortic arches. Okay, that's called brachial aortic arch. So you have here, you have trunk arteriosus. Just remember this. So the aortic arch, take this piece. You have here the trunk arteriosus, and then the aortic arch start having or classify to 2 parts. You have the ventral and the dorsal part. The ventral part form the aortic sac. The dorsal part, and that's later on is gonna make the descending aorta, and you can see make the arches: first aortic arch, second aortic arch, third aortic arch, fourth, fifth, and sixth aortic arch, and then you have the descending portion of the aorta, and here start fused, form the aortic sac. Okay, that's the okay. After that, once the changes happen, after that still start the aortic arches, the pairs start degenerate, and that's when is the aortic arch starts formation. So let's start one by one. So you have the first aortic arch, you have the second aortic arch, both of them degenerate. The third aortic arch, that's what's gonna common carotid artery. Okay, if you remember, the third is the ABC. So the third one is the common carotid artery. So now we have the internal and the external carotid artery. So common carotid artery is formation from the third aortic arch. The fourth aortic arch, the right side gonna give you right subclavian artery. The left side is gonna give you the transfer or the portion of the arch of aorta. The fifth aortic arch also degenerates or disappear. And then the sixth aortic arch give you rise for pulmonary artery and ductus arteriosus. Let's repeat again. I know it's a little bit confused. So you have 2, 3, 4, 5, 6 pairs. Okay. Why it's important? Because usually the arch is the left side arches. So this one, left side arch, normal. Normal, it's left side arch. The second part or the right side, it's for the right subclavian artery. If the right side does not disappear completely, then you're gonna have the double aortic arch. If the left, that's one case. That's called double aortic arch vascular ring. If the left aortic arch or the left side completely degenerate and remain second, that's second aortic arch, and that's another cause of the vascular ring. Okay, let's very quick review what we or summarize what we said. So that's not the topics today. The first, second usually degenerate, except they're gonna give you the first, it's M, max, maxillary. The second stand for the stapedius, is stapedius. Okay, the C, the letter, give you the common carotid artery. The fourth, that's give you the four limbs, that's the arch, the left. Talk about the left usually give you the arch, the right give you a subclavian artery, and then the sixth, usually they give you the pulmonary system and ductus arteriosus. If the left side does not, if the left side degenerate and the right side remain, that's called the right aortic arch, which is not normal. The left side arch is the normal. So normal heart, usually you have the left arch. That's normal. How you gonna recognize the left aortic arch? Usually located left side aortic arch. That's so location to the trachea. You can determine if the aortic arch descended comes like the on the left side of the trachea. That's called left side aortic arch. If the aorta or the arch of aorta come on the right side of the trachea, that's called right aortic arch. Normally we have the left side aortic arch, not normal. The right side is not normal, usually disappear, but if they remain, that's called the right side aortic arch. Does it make sense now? Okay, very good. What's type of the aortic arch? We have true aortic arch or complete, vascular ring. We have true or complete vascular ring. The second type we have incomplete or incomplete vascular ring. So we have true complete vascular ring or incomplete vascular ring. The complete vascular ring, what's the problem with complete vascular ring? It's the surround completely encircle around the trach and esophagus. So if the aorta surrounding completely around the trach and esophagus, that's called complete aortic arch. The most common cause of the aortic arch by far, 40 to 45%, is the double aortic arch. You can see both right and left arch remain. So supposed to be, we are just to revise, supposed to be a right aortic arch, supposed to be disappear. Okay, and give you right subclavian branch of the aorta. If remained right arch and joined, merge with the left arch, and circle around the both trachea and esophagus, that's called complete aortic arch or double aortic arch. Double aortic arch, and give you, and complete means that's completely surrounding the trach and esophagus. So that's number one type. The second type is the left side disappear, the right side remain, that's called the right side aortic arch, but there is ligamentum arteriosus. And that's the make strictures around the, or encircle around the trachea and esophagus, and that's when you, that can cause compression symptoms, and that's when you have the stridor. You got it? Okay, very good. Incomplete vascular ring, that means incomplete circle around the trach and esophagus. We have different types. We have the anomalies of inguinal artery. We have the aberrant left subclavian artery or aberrant left pulmonary arteries. Okay, here's a couple of the picture. Just so that's the inguinal left pulmonary artery. So you can see the pulmonary artery, the right main pulmonary artery, and the inguinal of the pulmonary artery surround between the trach and esophagus. Another example of incomplete vascular ring is that you have the right subclavian anomalies of the right subclavian artery. You can see go all the way in back and surround the esophagus and the trach. What's the incidence of the vascular ring? Is around 1 to 3% of all congenital heart. Male to the female ratio is around up to 2% or 2 times. If you have vascular ring, there's up to the 50% risk of the other congenital heart disease like VSD, ventricular septal defect, the tetralogy of late, coarctation of aorta, or ductus arteriosus. Okay, very good. What's the clinical presentation? The clinical presentation of the vascular ring, it can be presented like any other presentation. It's hard to differentiate: stridor, respiratory infection, respiratory symptoms or distress like retractions. It can be wheeze or it can be stridor. So depending on the word, the obstruction. Cough. Also, it can present with esophageal pressure on the esophagus, dysphagia, feeding difficulties, vomiting. How to diagnose? Usually by echocardiography, and to confirm and to have the whole structure, anatomical structure of the vessel, you need the angio, either CT scan or MRI, either CT angio or MRI angio. Barium swelling can be diagnostic, but it's not always. What you can see, the indentation, you can see it. Is that done for all baby? You don't need it for all baby. Since you have an echo and CT scan MRI, that's more than enough. Especially if you use the echo and you can see it, okay? Bronchoscopy, if baby presents with upper airway obstruction, you are not sure what you deal with, then you might need to look for any other anatomy of the air or any other cause of the airway obstruction, including vascular ring. You can see the area of obstruction. Treatment, surgery, especially if the severe symptoms. What's the prognosis of the vascular ring? Usually, for those who go to the surgery, usually the prognosis is excellent. Okay? That's the CT scan angio. You can see spiral CT scan. You can see the aortic arch, the right aortic arch, encircle around the trach, and in the back there is esophagus. Another image, you can see structures here. Sometimes it's difficult to visualize, but another case of the vascular ring. Okay, so in summary, we discussed about airway anatomy. We discussed about the difference between inspiratory, expiratory, bivasic stridors. We discussed about the difference between stridor and wheeze. We discussed about different causes of the inspiratory stridor, expiratory stridor, and bivasic stridor. We discovered the choanal atresia. We talked about laryngomalacia, subglottic stenosis, focal cord paralysis, and finally we spoke about the vascular ring. I hope I covered the neonatal airway obstruction very well. If you guys have any question, feel free to leave a comment and I will try my best to reply. If you like the presentation, please don't forget to subscribe me. Thank you so much.